Okay, I figure we'll go ahead and get started. Thank you so much for coming here as opposed to like the luncheon or something like that. MSAs, could we close the door for us? Thank you so much. I think you're first, Talya, with the introduction, so just be ready. So today we're going to be talking on loneliness, inclusivity, and well-being. And as part of that, we are actually going to do some inclusive introductions before we get started with our talk. So I'm going to turn the microphone over to Talya to start.
Can you hear me? Yeah, great. Hi, I'm Talya. I'm behind the podium. I'm a PGY2 at the University of Illinois, Peoria in Peoria, Illinois. I use she, her pronouns and identify as white, Caucasian, with German, Irish, English heritage. I'm a fourth generation to grow up on my family's cattle ranch in New Mexico, and very passionate about rural medicine as well as wellness, inclusivity for all in our journey through medicine and training.
The next picture on here is Fatou Ndaw. She was not able to be here today. She uses she pronouns and is a Senegalese American fourth-year medical student at UEComp, who will be starting her EM residency at WashU in St. Louis in just a few weeks, actually.
Hey everybody, I'm Logan Weygandt. I am a cisgender white male who's also gay. I use he, him pronouns. I do academic work in wellness as well as diversity, equity, and inclusion. And I am dog dad to two really spoiled, misbehaved rescue mutts.
My name is Vytas, and I am a cisgender white male, use he pronouns, and identify as a proud Lithuanian American and proud Chicagoan. I am the assistant program director at Stanford University's emergency medicine residency, and I have an academic interest in trainee well-being as it kind of relates to workforce retention.
And I'm Christine Stehman. I use the she series pronouns and identify as white with remote German and Irish heritage. I'm a core faculty at UEComp in Peoria, where I serve as the Director of Wellness Education and Faculty Development, as well as the faculty lead for wellness. I am a non-mom, book dragon, world traveler, and avid Pelotoner with two spoiled huskies. So by the end of today, you'll understand the link between loneliness, inclusivity, and well-being in medical training, particularly emergency medicine training. You'll be able to describe how intersectionality can have additional effects on loneliness, especially in medical training, and you'll be able to create a toolbox to assist in mitigating their residents' and others' loneliness. So we're going to start by defining some terms. First is loneliness. We've heard this term quite a few times, especially recently. If anybody's seen Vivek Murthy, who was the Surgeon General during Obama's presidency, actually did a whole project on this and wrote a book. But loneliness itself refers to a subjective feeling of being alone or isolated, regardless of the actual presence of others. It is a complex emotional state that can arise from a lack of meaningful social connections or feelings of disconnectedness from others. Whereas social isolation refers to a lack of social contact or interaction with others, often resulting from physical separation, geographical distance, limited social networks, or other limitations. It can contribute to feelings of loneliness and negatively impact mental and physical health, but there is a big difference between loneliness and social isolation. Loneliness is a subjective feeling, while social isolation is an objective measure of social connectiveness. They are distinct constructs that should not be used interchangeably. For example, it's possible for those who are more objectively isolated to still feel unlonely. For example, all of us during COVID, we were isolated, but there were plenty of people who had really solid online or virtual communities and never felt lonely during the whole thing. But those who are less objectively isolated could still feel lonely. Like you may have been during COVID, you may have been interacting with people on a regular basis, but never really had a community or connectiveness and so therefore felt lonely during the whole thing. This underscores how loneliness is a multidimensional construct that encapsulates numerous factors. Then there's the concept of belonging. This is a sense of being accepted, included, and valued within a particular social group or community. It involves feeling connected to others and having a shared identity or purpose. Of note, Those of you, if you're familiar with Brene Brown, she talks about the difference between belongingness and fitting in. Fitting in is when you change to match a group so you can fit in. Belonging is when you're accepted, included, or valued for who you are without any changes. Centrality refers to the degree to which an individual feels integrated into their social network or community and the extent to which they perceive themselves as important or influential within that network. Intersectionality is the framework that recognizes how various aspects of a person's identity, such as race, gender, sexuality, social, economic status, etc., intersect and interact to shape their experiences and social positions. For example, a woman might have one experiences, a black man might have other experiences, but when you have a black woman, they end up feeling different feelings because of both the intersection of the female identity as well as the black identity. And finally, burnout. These are phrases that are used so often right now and may be a little triggering for you. Well-being refers to a state of overall health, happiness, and contentment, which encompasses physical, emotional, and social dimensions, whereas burnout, on the other hand, is a state of chronic stress characterized by emotional exhaustion, depersonalization, and reduced personal accomplishment. And as you can imagine, all of these are connected to one another. Loneliness and belonging are closely related, as feelings of loneliness can also often stem from a lack of belongingness or connectiveness to others. Intersectionality influences both loneliness and belonging by shaping individuals' experiences of inclusion or exclusion within social groups based on various aspects of their identity. And centrality within social networks can often affect feelings of belonging and loneliness, as individuals who occupy central positions may feel more connected and less lonely compared to those on the periphery of social networks.
So why does this all matter? These are pretty well-defined constructs, but they're beginning to be researched and studied a little bit more. And I think with any of these things, well, I think having a inclusive and healthy workforce is important. I think putting some numbers to the problem can be very helpful. So with loneliness, it's been proven that or not proven I should say, but it's been studied and suggests that 26% increased risk of mortality and loneliness are in individuals who identify as being lonely. There's also increased levels of stress hormones and inflammation. With regards to belongingness, with the S there, belongingness predicts lower levels of depression and anxiety associated with better self-rated health and lower levels of psychological distress. And belongingness has been proven to be very important in people's development, both in adolescence. Belongingness predicts better adult mental health, but there's also some evidence showing that belongingness helps even in adulthood in terms of forming your kind of personal identity and career identity. Social isolation, on the other hand, has been shown to have a 29% increase in mortality risk. There's been numerous mouse models that have shown that social isolation can lead to very deleterious health effects and even early rates of death. But in adults, it's been proven to have higher rates of cardiovascular disease, increased risk of depression, and suicidal ideation. And in emergency medicine specifically, I think it's really important to talk about. Our trainees have identified that 44% of EM residents reported experiencing moderate to severe loneliness. 39% of EM residents nationally have reported feeling a lack of belongingness within their residency program. And 29 feel that they did not belong in their training environment altogether. 32% of EM trainees also experienced social isolation during their training. And it's not just our trainees, it's us too. EM physicians have identified through numerous surveys, these data are from a couple different surveys, but 36% of EM physicians reported feeling lonely at least once a week. 28% of emergency physicians reported experiencing frequent loneliness, and 33% of EM physicians reported feeling disconnected from their colleagues. I believe 35% experienced social isolation in their workplace as well. And it's not just the physicians, the ED nurses as well, and our allied health professions. 27% report feeling socially isolated at work. And one study suggested about a third of our EM workforce altogether experiences loneliness. or social isolation and a lack of belonging.
So going back to the concept of loneliness and connecting it to EM residency. As both Dr. Stehman and Dr. Karalius mentioned, loneliness is defined as subjective distress resulting from discrepancy between desired and perceived social relationships. Loneliness has profound impact on both mental and physical health. Indeed, perceived and objective social isolation increase the risk of mortality comparable with smoking and obesity. Loneliness is also highly correlated with depression. This is all the more concerning given the fact that the prevalence of loneliness has doubled in recent decades. So the structure of emergency medicine, organized chaos, working individually with our attending at different shift times and in different pods from our colleagues, all contributes to a very isolating experience training in emergency medicine. Our shift schedule, a regular shift schedule means fitting in 60 to 80-hour work weeks with very irregular sleeping, eating, and exercising. After a short period of time, all goes out the window, living only to work. Little extra energy for much else other than working, which means less energy for connecting and socializing, which in turn feeds into the cycle of loneliness and isolation. So my intern year, the new kid on the block, awkward, naive, and a little scared. My shifts were shared with one or maybe two attendings. Occasionally I had overlap with a senior resident who I talked to, but connection was limited as both myself and they had little extra energy and time away from patient care. Exhaustion was beyond real. I could only keep my head down to work. Off-service rotations were a breath of fresh air for me. With colleagues to work side by side with, we bonded over shared patient cases and working long hours together. The attendings had much more time and bandwidth to teach. Medicine felt like a team sport. Returning to the ED after being off service, I began to wonder what prevented me from connecting with my colleagues, even in the short moments I had to connect with them. Imposter syndrome. No matter how hard I had worked to get here or the accolades from my co-residents and attendings, I somehow still didn't believe that I belonged or that I was good enough. I was scared of being vulnerable. I was scared to share my experience of my training, my patient cases, and my experiences in the emergency department. This further led to my isolation. As a second year, I have found the courage to be vulnerable with both new interns and off-service rotators, as well as my colleagues, talking openly about the struggles of residency, the ups and downs, even when it feels like we don't have the time or energy for it. So what if I get one less chart done? My hope is that by being open and sharing, they will feel the courage to do the same. I have found this is how connections are started, strengthened, and maintained.
In addition to the challenges and difficulties we experience in our training and development of becoming emergency medicine physicians, we would be remiss not to mention the COVID-19 pandemic, which only served to exacerbate the problem at hand. One systematic review demonstrated a significant increase in loneliness overall during the COVID-19 pandemic, and another study showed that emergency physicians reported being more stressed, anxious, sad, and lonely. And while the story that Talya just shared is specific to residency, there are issues with other times during emergency medicine. Fatou was unable to be here, but she wanted to share her experiences of being a student, in particular a Black female student. Her EM rotation was the first rotation where she didn't have other students with her on a daily basis, and she was just one of many students that rotated in the ED within a number of different attendings who she might only see once or twice. She describes as being nothing but a ball of nerves entering what felt like a very high-stakes environment, not knowing the dynamics or culture, not knowing when or how to introduce herself to attendings, worrying that she might be labeled as too aggressive or angry or unapproachable if she didn't smile enough because she'd had that situation on other rotations, and concerned that she would forget to present pertinent information and tank an evaluation that held so much weight towards getting into residency. She did feel lucky when she had a resident or attending who took her under their wing and reminded her that she was doing well or pulled her aside to see her do a procedure, but sometimes that was few and far between because it was her and one attending for a whole shift, and if that attending wasn't that person, it might be a very challenging shift for her. Additionally, the risk of experiencing loneliness and isolation doesn't end when you graduate. In fact, in some ways, it might actually get worse. You start residency with a guaranteed group of cohorts. I think the smallest residency right now has 4 to 6 in a year. So you have 4 to 6, 3 to 5 new friends. But when you start as an attending, you might be the only person who starts at that place. And if you started at a place that you didn't train, you don't know anybody, you don't know that culture. So you have a whole other level of trying to make new friends, right? It gets harder as you get older.
All right. We've talked about the problem, which is serious in emergency medicine, but this wouldn't be a solid didactic if we didn't tell you what you could do to help prevent and mitigate social isolation and loneliness. So many of our solutions are focused on building social cohesion and belonging, and therefore focus on the social dimension of wellness. However, it's important to also consider the other aspects that may influence a trainee's wellness, including spiritual, emotional, physical, environmental, and intellectual. I also want to provide the caveat that we are sort of approaching this from the residency lens, but many of the strategies that we're going to provide today can be easily adapted to the student or clerkship environment, to fellowship, or even to that junior attending experience. All right, so the strategies we're going to cover today, and this is not an exhaustive list, but these are things that have worked in our own programs, include providing a orientation experience that's structured and thoughtful, fostering supportive mentorship, offering inclusive social events, supporting affinity groups to increase a sense of belonging, and then ultimately displaying signals and imagery that enhance inclusion and a sense of belonging. So intern orientation. This is a crucial time for new trainees and offers the opportunity to begin professional identity formation, as well as create that sense of belonging early on and ideally mitigate social isolation. So if your intern orientation experience is structured in a thoughtful way, this can really have a lasting impact and sort of set the stage for what's to come for the next 3 or 4 years. One strategy that we use at Hopkins is a facilitated museum tour, which has been shown to increase group cohesion, enhance a sense of community, and then help interns to sort of navigate the idea of their own identity and new role as physicians. Other strategies include group simulations, bringing in folks from across the care team, specific didactics focused on marginalized populations, time to meet and greet with leadership, and then ultimately ample time for social interaction. Another area that is easy to provide structure for your residency is mentorship. Mentorship provides myriad benefits to the mentee, including personal and professional satisfaction, increased confidence, and a pathway to academic success. Mentorship also offers the opportunity to combat social isolation for both trainees and faculty. If mentorship is focused on shared identities, it can further enhance the sense of belonging, but we don't have to stop there with shared identities. Even if you can't provide mentorship based on shared identities, residents can benefit from these relationships if we're thoughtful about how we go about them. Mentors need to be reflective, honest, and approach mentorship with a growth mindset. And mentors must also engage on how their mentees' identities may impact their training. So things such as race, sexual orientation, socioeconomic background can have profound impacts on trainees. And if mentors practice what's called protective hesitation, where they avoid those conversations, they can actually further isolate their residents. But by having discussions around structural and systemic racism, sexism, and other isms, we can really enhance that sense of belonging and avoid that protective hesitation. Other things we can do, this is our 5K run walk for wellness. It's a really fun time. It's coming up in the spring. If any of y'all are in Baltimore, June 1st is the date, so please come on and join us. But these social events can help combat things that are structurally set up to create isolation in residency, the things that Talya mentioned, such as long work hours, prolonged screen time, our complex EMRs, et cetera. Additionally, social events such as faculty dinners, which are designed to really flatten the hierarchy by offering the opportunity to share a meal in a casual setting, can help residents feel welcome and to not feel sort of as afraid of their attendings as they might be. You can provide facilitated discussions, sort of these open mic night kind of things, but it's important for them to be structured. These allow for us to discuss difficult cases, feelings of imposter syndrome, and sort of focus on work-life integration. There are a couple of things called ballot groups and Schwartz rounds that you can Google Scholar, and there's good evidence for these for helping enhance belonging and mitigate loneliness. You can have wellness events such as the 5K I mentioned, exercise classes, facilitated mindfulness meditation, and these can really focus on physical, emotional, spiritual well-being, et cetera. And then finally, residency retreats can truly be an excellent way of building social belonging and cohesion, but it's important to provide a structure to them in order to make sure that everyone is included. One word of caution. Often social events will be designed in a way to enhance inclusion, but they can be exclusionary if we aren't thoughtful about how we do them. So, for example, if all your events revolve around kids and folks with kids, then folks who don't have kids may feel excluded. If all of your social events are focused on exercise, those who have differences in ability may feel excluded. And if social events only focus around alcohol, folks who don't drink alcohol may feel very excluded, and especially those who are struggling with addiction may really feel excluded, isolated, and lonely. So it's important to really have a diverse set of social events and then to also think of how they may be exclusionary even though you're trying to be inclusionary. Affinity groups are a lot of fun. And there are good data to suggest that race-based affinity groups enhance a sense of belonging and community. Groups such as house staff, minority councils or groups can also provide the opportunities for trainees to speak freely about issues related to systemic and structural racism. They provide networking, mentorship, and community engagement. Affinity groups can be based on race, gender, sexual orientation, parents, non-parents, et cetera. And this is a photo of our LGBT affinity group at Pride dinner, or Pride brunch last year, and it was a lot of fun. Another thing to consider in your physical spaces are the symbols we display and the portraits that adorn our walls. Portraits displayed on walls have been shown to be a visual demonstration of institutional values, and we have to think about how that may impact our learners and the folks that we work with. Lack of diversity in institutional portraiture has actually been shown to produce the feeling that folks don't belong. And so we need to consider what's in our spaces and how they might generate feelings of exclusivity or marginalization, or if they demonstrate a culture of inclusion, which is what we're really focused on. And then finally, even if we aren't interacting in a physical space, especially since the COVID pandemic, we've been interacting increasingly in virtual spaces, there are still ways that we can send signals of inclusion. This can include the clothes we wear, the objects that we have in the room, the pronouns we display on Zoom, or a simple pin, lanyard, or sticker. So these are just a few of the strategies that have worked for us. It is by no means exhaustive. We would love to have a dialogue and hear what's worked for you to help build inclusion, belonging, and fight loneliness. So we have an extra mic. Please raise a hand, shout out. We want to hear what y'all do. And otherwise, we would love to share contact information and learn from the things that have worked for you.
Honest, you guys do exactly the same things we do, or does anybody have any other ideas of what we could, because I'm also willing to open up to what I can do differently in my program. So does anybody do something different or they found that is particularly helpful? Or students and residents who are in the room, anything that you have found that you wish you had, or you're like, hey, I really have found this super helpful? Nobody?
Hi, my name's Christine. I'm from Virginia Tech Karalius Clinic. I'm a first year, I'm a PGY1 resident, and I feel extremely blessed because our program, I think, does an amazing job at everything you just talked about. Specifically in the fall, well, beginning with orientation, there were a lot of mandatory resident bonding moments, and we were also set up with second year mentors before getting our actual faculty mentors as well. So immediate mentorship, lots of activities in the beginning, like you said, and then our wellness retreat was actually 45 minutes out of town. We spent the night at a camp and had all these wellness activities that were very structured, some of them academic, some of them more wellness associated, but it was a structured retreat, and they really set aside time for us to do that for 2 whole days. So I feel
That was the beginning of the residency, so
Yep.
you had a chance to kind of get to know people outside of the department
yeah,
beforehand?
definitely. So it's been a really positive experience at that program, and if you want to get in touch with any of those attendings, they're great.
Does anybody else have any other experiences they'd like to share?
I have a question.
Of course.
So, I'm Robin Paulson, Vice Chair of Faculty Development at WashU. I find that for those of us that have been in this career for a while, and we knew a pre-COVID world, and then you had pandemic, and we're trying to revive a lot of in-person groups, whether it's faculty development time, affinity groups like you've mentioned, opportunities that are open for residents and faculty to join. And it's great, people say, oh, I want these opportunities, thank you, but then it's hard to get butts in the seats. It's hard to get people to come. How have your departments balanced that tension between kind of coming back to the virtual space and, balancing that with their own perceptions on their wellness as their time?
So I know for us, the 2 groups that we have, so Talya is a resident in my program, and we have a women's night every month. It's the second Wednesday of the month, and the chiefs have been fantastic about actually not scheduling any women who are in the ED. They do not get scheduled on a shift that'll cross the 6 to 9 time frame so they can come. It's not technically protected time, but it is their journal club is protected time. They're required to be there, and so we get all of our residents there, and we have a pretty good number of faculty that show up. I'm probably not the greatest representative of the rest of the core faculty, but I have 5 mentees, and I've adopted 2 other ones, and we find a day 3 months in advance, and they ask off for it, and I have them all over to my dinner, or all over to my house for dinner every quarter. But I plan it based on my schedule, which I get my schedule 3 months in advance, and then they don't get their schedule till a month in advance, and so they usually ask off for it. And their spouses and kids come and everything. So Logan and Vytas, what have you guys done to help? But again, making sure we have the protected time and getting buy-in from higher ups has been super helpful for us.
The advanced scheduling that you're talking
Yes.
about.
Yes. We haven't been successful about getting any. We have 2 core faculty that are female. We have a 3rd one who's starting in July, who's there as a fellow right now. So we're really good about getting there for the women's night. Getting our non-core faculty, clinical faculty there has been a little bit more challenging, and we're still working on that one.
Say that point specifically causes me more stress than almost any other, because I know these people have a wonderful time together, and that this will build that sense of belonging in the community and all the things we want, and that, well, it's my little time off. I'd rather just be at home with my family. Darn it, that makes sense too. But the biggest success I've had on that front is peer champions within whichever group you are trying to build cohesion within, having them speak loudly about the importance for them within their community, and that's been a big motivator to bring peer residents or peer students together more than faculty saying, please come, if you can have someone who can be excited about that, it's been really helpful for us.
We also are a very family-friendly residency, so like I said, my house is almost getting too small because I have now 7 residents, and we have 4 kids among the group, and everybody has spouses, and so it gets a little bit. And our journal clubs, we have kids at most of our journal clubs unless the space is really small. So we have spouses and kids, and actually to the point where there are times when we'll have a faculty member over there playing with all the kids so that the residents can be grown-ups. We're not quite to the level of Ohio State where the faculty will actually babysit the kids. We're not there yet, but.
I just wanted to add one point on that I think it's important then, just like from a resident level, and I guess going through this as well, is what does wellness mean for us? Does that mean like going home and spending time with your family? Like that's the thing to do. Or is it like a desired social situation that is not there that, maybe we can work on creating? I think just in my reflection and just now getting to a point where I'm, really talking to my colleagues and seeing what does that mean, so.
And you also have to pick what's right for you too, right? I'm a hardcore introvert, so there are days when I'm like, technically I'm supposed to be at journal club today, but I've already peopled too much, right? And there are other people who are like, no, I need to be there because I need to be around people if they're hardcore extroverts. So Logan and Vytas?
I think we struggle with similar struggles, especially coming back from the pandemic. And, I think it's a little bit of, if you build it, they will come. Some of our earlier events shortly after COVID had like 5 or 6 people at them, but it's easy to sort of let the wind fall out of your sails and just sort of sit idly. But if you keep these things moving, and especially if you can get some resident champions, I find that it helps a lot. Also, if you can have them sort of blast the group me, that sometimes is an effective way of accessing folks.
Yeah, I think we all struggle with this, right? Like you can lead a horse to water, but you can't force him to drink. But I argue like maybe there's certain creative ways that you can, in a way, force them to drink. For instance, our residents have Tuesday evenings protected for Wednesday conference, and sometimes certain classes will utilize that time better than others to get together, bond, and do things. But one thing that we had done was once a month we decided to actually make a mandatory journal club. It's part of our didactic, required ACG and me education time. But then it kind of also forced everybody to get together as a residency for that journal club. We provided food, we did our journal club, we did that didactic component, but then it's kind of, you leave them there and they hang out, they're able to have like a beer, eat some food, hang out, maybe go do something fun with their class afterwards. So in a way, kind of more strongly leading them to water to drink, if you will. But so kind of trying to figure out clever ways, or maybe even like certain ways that it could be required, knowing that that might be beneficial to them, could be like one approach to it.
You mentioned the Tuesday nights protected. We also, again, we have fantastic chiefs who really make an effort on the schedule. We have each block, there is one night that's a third year block night, a second year not block night, and a first year block night, so that there, again, none of the third years are scheduled between like 5 and 9 and so on. So there's a chance for them to get together. And they've really made an effort to make this happen. It's not perfect. It's not always 100%, but for the most part, they try. So each block, there's a third year night, there's a second year night, there's an intern night, as well as the women's night and the journal club. So there's a lot of opportunities that are there if they want it. They don't have to. Like, we're not saying, hey, if you don't go to the third year night, you have to work, but it's there if they want to use it. So, yes.
In my experience, one of the things that I've seen repeatedly is that it's not a failure even if you only have 4, 5, 6 people show up. I feel like a lot of times the smaller, more impromptu meetings and opportunities for discussion have just as much benefit, if not more, because we're not going to be able to talk to the whole room at once if there is a large meeting. And those types of events are often harder to bring together. But having a slightly less packed schedule in terms of a conference that makes space in between lectures for people to talk compared to the more densely scheduled events. Simply like after shift, having a physical space and a culture that promotes conversation after shift, I think are all very small, hard to spot, but also very important aspects for promoting wellness and combating the feeling of aloneness. So I think that oftentimes, again, even if not everyone shows up, it can still be a very useful thing, just creating a small gathering. I
think being really cognizant of scheduling is, I think, important too. Where I trained, the second year is, like, I think for most of us all, was like very difficult. And in our second year, we uniquely worked 12s, whereas the rest of the department worked 8s. So all of a sudden, you're not ending at the same time as all of your colleagues. And so made kind of for that socialization after shift or before shift a lot harder, because you kind of were working through the change of shift. And so they had actively made a decision after our year to go back to an 8-hour staffing. And I think that significantly improved the wellness and kind of that inclusivity that you felt as part of the team, being that you showed up with everybody, you left with everybody, as opposed to kind of just being there as everybody's passing by. So I think kind of being cognizant of staffing can be really important too, and try and get teams off at the same time, so multiple teams can like finish at the same time and maybe kind of hang out after work, I think is really helpful too.
Yeah, in my residency, everybody did 8 to 4, 4 to midnight, midnight to 8. So you had chunks of people who would go out afterwards. Now we have on my current place, we have a very waterfall schedule. We will have some times where, especially the evenings, we'll go off and get drinks. But again, then you're going to a bar because that's what's open at midnight and might serve food. And then we have had residents and attendings who struggle with alcoholism. So we're basically excluding them. So you have to, there's all sorts of things. You obviously can't include everybody every time, but it's worth considering and making sure that you're not obviously saying, I don't want you there, right? So we've heard a bunch from this side of the room. Does anybody on this side of the room have anything to say? If not, I don't care. I'm happy. We can end early and give you back some time, but I just want to make sure everybody's heard. Okay. Well, if nobody has any other questions, we'll finish early. We'll stay up here if anybody wants to get contact information or ask questions without the microphone in their face.
I did have one question. When you were talking about the stats earlier about EM physicians, around 30% or so suffer from this and that. How does that compare to other specialties or the general public? I'm curious, is it dramatically more or a little bit more?
From like some of the literature that I was looking at, certainly the social isolation aspect was significantly more in emergency medicine. I think largely due to kind of our shift work nature was a lot of kind of what they would point to, I think, as kind of one of the root causes. We don't have a workroom where we sit around and do notes and chat and like have community, right? Like it's kind of just a rapid paced job, and then it's like you clock in, clock out, and you're out. So it seemed like it's, at least with like the social isolation components, that EM was significantly higher than like their colleagues. And then as a result, I think that kind of trickles down to like the feelings of loneliness or, and things like that. So with belongingness, I'm not sure how that really, it seemed like, at least from a trainee standpoint, surgical residents had a very difficult time with like feeling belongingness and not feeling like they were in an inclusive environment. That seemed to be kind of the worst off. But yeah, otherwise kind of at baseline.
Anybody else? Okay, thank you so much for your time. Like I said, we'll stick around for a little bit if anybody wants to talk without a microphone in their face or just get our contact information. We're happy to continue this conversation afterwards. Thank you for your time.